what do you do in the surgical population? Or are there patients that maybe before we would have considered surgery, but because of these very positive results, we would go the chemoradiotherapy route? What are your thoughts there?
Yeah, it's a great question. This is one that comes up clinically all the time. So here we've got a tremendous advance with durvalumab from the Pacific study. It adds a very clear benefit. But it also raises the question, should we discard the benefits that other treatment paradigms may bring in there? There was a study done by the CalGB, led by Kathy Albane, a little more than a decade ago, where they asked the question, can surgery add benefit for stage 3 disease? And there were a couple of take-homes from that. So overall in the stage 3 population, it didn't add benefit. But if you took the group of patients who got surgery after chemoradiation, and it was only a lobectomy, not a pneumonectomy, that group actually got an appreciable difference. They had longer survival, overall survival and recurrence-free survival. And so our practice at MD Anderson is if somebody is potentially a surgical candidate, we try to integrate that with the other treatments. For example, if it's a single station, low volume disease, or perhaps 2 stations, but low volume mediastinal disease, or if they clear their mediastinum after chemoradiation, or in some cases chemotherapy, then we do consider surgery. Now, in the Pacific study, surgery wasn't one of the options. Everybody got chemoradiation, and then were randomized to durvalumab or not. But this raises the question, if somebody got chemoradiation and was a surgical candidate, do you choose between surgery or durvalumab, or do you put them together and say there's a benefit from surgery, there's a benefit for durvalumab? So here I have to say this very cautiously. Our practice is to certainly consider integrating surgery with the recognition that it isn't exactly what was done in the clinical study, but here we're inferring there's no reason you shouldn't get benefit from both of those. And I think this is a great subject for future randomized studies. Yeah, we're excited about exploring, for example, induction chemotherapy and immunotherapy, integrating surgery where possible on top of radiation and immunotherapy afterwards.
Yeah. And Heather, your thoughts about that question, and maybe just comment a little bit on the trials ongoing in the truly adjuvant setting.
Sure. So for this particular study for the Pacific, I mean, for a patient who would have been a candidate for surgery, I still think you need to decide that beforehand, right? You don't want to start with the chemoradiation and then say, oh, maybe we should go to surgery. I mean, these are always patients who need a multidisciplinary discussion and a tumor board up front, ideally. So in our practice, we're still making that decision, surgery or not, before we start any treatment. For those who aren't getting surgery, we absolutely are following the Pacific regimen, which fortunately gives us a lot of leeway with the chemo, but then adding in the durvalumab afterwards. We haven't yet done that for a patient who then went to surgery. We're sort of putting them into the different camps, and it's tricky because for the ongoing post-operative trials looking at immune therapy, none of them are allowing for patients who have, unless it's defined up front, who are getting the chemo and radiation before that surgery. So it's a little tricky. So we do have, for our patients who are earlier stages who have gone to surgery, or the sort of surprise N2s who've had their surgery done, then we do have open trial looking at giving them adjuvant. In this case, it's the ANVIL study. We had other immune therapy studies open in the past. And just for the audience who's not aware, maybe there are 4 global studies going on looking at adjuvant immune therapy, either giving, there's a nivolumab study, and that's the ANVIL study. There's a pembrolizumab study and a atezolizumab study, several others as well. No, there's the durvalumab study.
And ANVIL is part of the Alchemist, the greater trial.
ANVIL's part of the Alchemist, yeah. Right? And so they're all very similar design, but we don't really know yet about giving these drugs after surgery. We just don't have that data back.
Stay tuned.
Exactly, those are all nearing, I think, enrollment. But there's also then, I think, getting back to this question about what do you do about giving it, what if you've already given them the treatment ahead of time? And that's where there's so much neoadjuvant data now coming out, and obviously MD Anderson's been leading some of that work with the NeoStar study that was presented at ESMO this year looking at nivolumab or nivolumab ipilimumab, but those weren't with chemo. And I think where all the cutting edges is, do we do chemo with immune therapy? Do we do immune therapy alone? Do we bring the radiation in before the surgery or more often after the surgery if it's a known N2. And for some of these ongoing neoadjuvant trials that are looking at chemo plus immune therapy, they do allow for the radiation after surgery if it was an N2. So that might give us more information also. And it sounds like you had something else to bring in.
Yeah, well, you know, and I agree with all the things that Heather said in talking about these, you know, these results. And obviously we're going to have a lot of new exciting data coming out soon. You know, one really interesting one presented at ESMO, led by a Spanish group, was for a single station N2 disease with chemo and nivolumab, you know, where it had an extremely high response rate, you know, and that's actually a regimen, and we're actually testing neoadjuvant chemo and nivo right now as well. But you know, today, I guess in the clinic, if you've got somebody that had low volume mediastinal disease, they responded well to chemoradiation, and they were a surgical candidate, you do have to make a choice after that surgery. Do you give them durvalumab or not? Mm-hmm. And you know, it happens in common clinical practice that you know, that the way you're treating somebody isn't exactly what's followed on the study. You know, given that we do have to make a decision, I still lean towards giving them the potential benefits of the adjuvant durvalumab while explaining to the patients the limitation that, you know, that's not exactly the way the study was followed. But I realize it's a debatable point.
My only concern about that is, you know, establishing the safety of that. You know, we don't have large studies, phase 3 trials that would define the safety of that.